All right. We're back on Health at Work. Got a good one for you today. We got Matt here, who is an ex-healthcare reporter, spent time on DC, Capitol Hill, mostly reporting on healthcare and ACA for about 5 years. So he got a front row seat really to a lot of the changes that happened that are driving what we're seeing in the healthcare systems today. So we're going to get a unique perspective on his take on some of those changes and what that means for us today, especially now. He's with Willis Towers Watson as Director of Health and Benefits, where he's been there for about 2 years, and he has spent the last decade plus in the benefit space, really educating employers on how they can get great benefits while also decreasing the overall cost profile. So it's a really unique perspective we're going to get from Matt today, and we're super pumped to have you on the show.
Thank you. Thanks for having me. Appreciate it. Glad to be here.
Yep, absolutely, man. So, like we mentioned, you kind of had a front row seat as a healthcare reporter. So just kind of give a broad overview. What was it like to be a healthcare reporter?
It's interesting, right? Because, Congress are not, and members of Congress, most of them are not experts in any one particular field, right? Some of them are, PhDs or something, or they've got they were medical doctors, or they had a business or something like that, right? But most of them are not real technical experts. And so you would hear these things, come out, and especially now kind of looking back at it. I'll give you a great example, right? So we've seen in the stop loss market, large claims really starting to get growing, right? A lot more prevalent large claims. And when did that happen? It happened after the ACA banned or banned caps on like lifetime insurance caps, right? So what did that do? Well, to a politician, it sounds like a great thing. Hey, we're going to stop these bad insurance companies from capping your benefits. Well, yeah, except that now what you did is you made it an unlimited benefit. And what did some providers do, hospital groups, right? They just charged whatever they wanted. And that's, so you see that kind of stuff. Like you'll see them kind of go like things they think are great ideas, getting rid of medical underwriting, right? Sounds like a great idea to somebody who doesn't understand insurance or doesn't understand healthcare at all, right? And then what does it result in? It results in providers or insurance companies that can't underwrite their products. So what does that mean they do? Well, they're required to be fiscally sound. So now they have to charge you, the consumer, the most expensive rate possible. Why? Because they don't know whether you're sick or not. And that's what health insurance really is. It's like sickness insurance, right? Sickness and injury insurance. So, they don't know who's going to get sick and who's not because they're not looking, because they can't look. Government said they can't look anymore. They banned the underwriting. So what are they going to do? But to a politician, it sounds great. It sounds really good to go do a lot of this stuff. And so you'd hear them talk about this. And then, the other half of them, you'll hear kind of like academics and economists talk about it. Again, people that don't have real experience in it, but they kind of have experience like thinking about it or, writing about it professionally, right? So it's like, we're going to bend cost curves down. Well, you didn't do that, and it's like, the reason you didn't do it is because you broke a bunch of the things in trying to fix it that were being used to control costs, underwriting standards, price cap, right? Like, caps on annual spend and stuff like that in insurance plans. So that's what it was really like. It was kind of like watching, like your brother-in-law fix your car, but your brother-in-law's not a mechanic, right?
High levels of confidence there for sure.
Yeah. Right. You got more confidence and you got expertise. And so, he's in there with a wrench and a screwdriver. You're just like,
And I don't like getting political too much, but it seems, especially when it has to do with healthcare, the solutions always seem very nearsighted. Like, let's solve this problem that we have today without really considering a longer time horizon. What's that going to look like in 5, 10, 15, 20 years? Because, what time period was that 5 years you spent healthcare?
So that was 2008 and 2013.
Okay, yeah. So we're seeing the long tail effects a decade later of what was being set into motion then.
Oh, for sure.
And so Yeah, yeah, and so I think it's kind of across the board with politics, but especially healthcare. We've just seen one thing after another where they put something in place that's designed to help maybe a specific group of people more, but it ultimately hurts everybody more over longer periods of times because we're seeing the rate increases. I mean, just skyrocketing, and it's a mess, man. So I just think from your perspective, it's kind of interesting to see like, oh yeah, these are the things that were really going sour while I was reporting, and now
Well,
you're picking up the
it was
aftermath.
it was really interesting to see all the stuff that they like didn't do, right? So like 1,000-page piece of legislation, it's going through, I think at the time 5 different committees and 2 in the Senate and 3 in the House, and it's like so 5 different working versions of basically the same idea, And it's interesting to see like things they left out, right? Like price transparency. I mean, for years it took them until just a couple of years ago to finally say providers have to disclose their prices, right?
Yeah,
And of
but
course,
are they
if you do
enforcing
this,
it?
no, they're not, right?
Yeah.
So now they're not enforcing it. And of course, like, the provider groups and the insurance companies and all that, like the pharmacy carrier manufacturers and all that, they lobby really hard and spend a lot of money on keeping stuff like that out of bills. I mean, price transparency was talked about at the time, and I remember it, but they didn't put it in there. And the reason they didn't is that it was basically the unspoken deal between themselves and the AMA, because what they wanted was endorsements of their bill, right? They didn't want the doctors lobby, basically, right, to tank their effort. So they didn't make them disclose all their prices, even though they technically already do. It's just that they do it to Medicare, and the way Medicare takes those files in is, unless you really want to spend, make your eyes bleed reading a manual spreadsheet, you're never going to know what these hospitals all cost, because they don't make them easily publishable.
Sure.
But they're there. By law, they have to
Yeah.
tell Medicare what it is they charge for knee replacements and X-rays and all that kind of stuff.
Yeah. And I don't know the answer to this, and you might not either, but I'm always curious, like, obviously the political side of healthcare, it's intertwined in how do we drive policy to change healthcare in a way that could be good for people. I mean, I think like nobody's trying to do the wrong thing,
right?
But like, how intertwined are politicians in big healthcare? Like, actually,
some of them are real intertwined in it, right? So, like, I mean, some of them were. I mean, I think one of the senators from Florida ran a large hospital. He's like a hospital CEO.
Yeah.
But even the ones that weren't like directly working in it, some are doctors, some are medical doctors, and some were back then. But a lot of them, the intertwining is more on the like pure political side of it, right? So like, and I think maybe that's what you're getting at. It's like, yeah, a bunch of them are, they'll go on to serve on boards of, healthcare companies or pharmaceuticals, or so. A real bad one is this kind of weird pipeline between the FDA and the pharmaceutical companies, right? So like, you'll have heads of the FDA that, when they're done being the FDA administrator, right, they go and they sit on the board at GSK, or they sit on the board of some pharmaceutical company, and they're not doing science, right on the board. They're not in the lab with a lab coat inventing new cures or whatever, right? What they're doing is they got the Rolodex out, like any board member. That's what you do, right? They're there for the Rolodex of, okay, if we want to get our new wonder drug, our weight loss injection or patch or whatever it is that we're going to come out with through trials, who do we got to talk to? What do we got to do? So there's a lot of that, and a lot of, on the politician side, obviously it's not quite as linked that way, but it's behind the scenes. It's lobbying dollars, and then one thing that I'll get up on a little soapbox here, but nobody talks about, is that they're all invested in these companies. I mean, they are, and I was there when they finally, after decades, banned insider trading by members of Congress. So right up until the financial crisis, it was entirely legal for members of Congress to do what if you and I did it, we would go to jail for insider trading, right? So if they knew that a regulation was going to come out that was going to hurt, a pharmaceutical company or a healthcare company that they were invested in, they could sell the stock early and short it, right?
Yeah,
and then
yeah,
make
yeah.
on that, right, get out before they lost money, or vice versa. They go buy a bunch of it cheaper before the price went up.
Yeah.
And so until but 2008 or 2009, I think, that was legal. That was entirely, they had exempted themselves from insider trading laws. And so they're all, if you look at the politicians that are on these healthcare committees, the health and welfare, labor and pensions, things like that, right? And if you look at their financial disclosures, which they publish, their stocks are all in whatever their committee regulates. The guys on the energy committee are invested in oil and gas, nuclear, right, wind farms, stuff like that. The health and welfare, labor and pensions people, they are invested in, and you can just look at them like they're invested in everybody you'd think.
Yeah. That's crazy.
Oh yeah.
Crazy. So what do you think? It's like, what out of that time period do you think was a net positive? Was there anything that's really like, now that we're 10 years later, 15 years later, is there anything that's like, yeah, that actually did something great? Or let's just say overall, what do you think?
So
in the last 15 years, net negative or net positive on healthcare?
Looking back, net negative. I think the positive is it helped the ACA and those reforms helped people who were what we would call uninsurable at that time, right? Chronic diseases or a history of chronic disease, right? So, I mean, I'll leave you a great example. So, like, my mom had cancer 3 times when I was a kid, right? 3 different bouts of cancer from when I was like 10 to I was like 18 of breast cancer, right? So my mother is one of those people. Now, my dad actually worked for the Defense Department. I'm from back east, outside of DC. So he actually worked for the DoD Defense Department. And so, like, they had employer-sponsored health insurance, right? Like, through them. But my mom on her own is uninsurable. Prior to the ACA, no way, no health insurance company would have touched her at any affordable rate, right? They probably would have, the pre-existing condition thing, right? That's a positive.
Yeah.
That's a definite positive, right? Making it so that it's basically a guaranteed issue is the insurance term, right? So making it so that it basically is a guaranteed issue product. That's a big net positive, really, for everybody. And the ACA it helped people like that who, were largely uninsurable or extremely expensive to insure. It came at the cost of kind of breaking a market that worked for everybody else, right? And that you see this kind of in the individual market, which is a lot more difficult now. I do think a positive, I think the exchanges that happen are positive. The products on the exchanges are not as great as they used to be, right? The individual products, but in the small group market is definitely not as good as it used to be, right? That hurt. But the exchanges for individuals, a centralized place, an easy place like Amazon, like it's like Amazon for buying anything else, right? So that's good. And I think employers can take advantage of that now too, because they can now have those ICHRAs, right? They can go and say, okay, well, there's 200 of us and we don't want to fool with a group plan anymore, but we want to give a stipend and help our people get coverage. And they can do that. And it's now very easy to do. That would have been really hard to do pre-ACA. You had to have a really sophisticated broker partner to be able to do that. And now it's a lot easier. So, I mean, on balance for the whole country, no, it probably didn't end up being a great deal outside of the pre-existing condition ban, which is a great deal.
Yeah, for sure. Yeah, I think that's interesting. Do you think those particular changes kind of the start of driving up overall costs? I mean, I know that's multifaceted. There's so many things.
Yeah.
But was that like the gateway? Was that the gateway for like the
it didn't help. I'll put it that way. So medical inflation prior to the ACA ran hotter than the rest of the economy anyway, right? Medical prices grew faster than the prices of milk and eggs and gas and tires and stuff, right? So, okay. The whole idea was that they were going to try and clamp that down, and it didn't work because of some of the things I mentioned earlier, right? They lifted the caps on lifetime insurance policies. They banned the underwriting in the small group space, the medical underwriting, all that sort of stuff. And most of your employers are small, right? The vast majority of employers are small businesses, so they don't have large groups, and so they don't have that buying power necessarily. So they're buying insurance, they're not self-insuring. So those two things, yeah, I mean, like, and it's you can see it like over time, like you can see. And I remember, like, I had just gotten into health insurance when the ACA was being rolled out, because it passed, and then they waited a couple years, right, to like get all their ducks in a row before they locked it in. And like, you saw the insurance rates pop, you saw the small group market just erode. And now what you're seeing looking back is, a spike in large claims, right? And I think what you're not seeing is, it's not the procedures and the diseases that are becoming more prevalent, it's the cost of treating them. You're seeing more and more of these large costs of treating some of this stuff. And the reason is that provider groups have realized that insurance companies have to pay, right? Insurance companies are, of course, trying to now find lots of weird ways of prior authorizations, or kind of like getting quite burdensome, right? Right, to try and stop them. You saw, really this kind of like, it's not a real HMO, right? But what we call HMO networks now, where you have to have the primary care provider, and you have to have a referral for a specialist. And so they try to gatekeep in that way that they didn't used to. And I said, those aren't true HMOs like a Kaiser, right? Where they own the doctors, but it's an HMO model. It's this navigated care model. And it really is like, they're all trying to find ways to play this hot potato with these uncontrollable costs. And it'll be interesting if they can ever enforce the transparency rule. That's maybe some hope there, because then payers can start to see not only like what providers are charging, but what insurance companies are negotiating, right? Like, who's doing that. So, because insurance companies don't want that known, right? So they try to keep that from being out there, because it deletes or degrades their competitive advantage, right? Right. So hopefully that can kind of come in, and we know that, like, from reference-based pricing models and things like that, or direct pay, direct contracting, direct primary care networks and things like that, that when you do have fewer things in the way of that payer-provider patient relationship, and that's as straight a line as possible, you do see significant reductions in cost, significant cost reductions.
No doubt. And there's a lot of information now flooding out on cash rates versus in-network versus out-of-network.
Mm-hmm.
And I think if price transparency ever takes hold, I think that, combined with the fact that, okay, here's your price transparency. If you use your insurance, it's going to cost you $3,000, but our cash rate is actually $900. That's going to be a huge like wake-up call for people. It's my opinion, just on the healthcare side, we see how people make decisions around healthcare, and they don't make it around quality of care. They don't make it around value. They don't make it around price up front. They make it around, can I use my insurance, yes or no? Mm-hmm. Because people tend to think two things. They think, I have great insurance, and they confuse that with getting great care, and those two are not the same. And then they think, I have great insurance, as in I pay a lot of money for this insurance, so the care I'm going to receive is going to be free or cheap. And it turns out that neither of those are true.
No.
And so I think it's going to really start to create some change if we can get price transparency through, and people can start waking up to the cash pay. We see it as a stable thing in rehab, where most people who have surgery, let's just say some type of orthopedic surgery, they're going to have that in probably November or December. And it's not because their life has been turned upside down and their quality of life has taken a drastic decline. They can't get around. They can't do the things they want. They're making that decision based on one piece of data. Do you know what it is?
Oh, it's their plan year. It's
their deductible's been met.
Deductible. That's right.
Yeah. It's like, my knee still hurts a little bit.
Well, we see
I've
it.
met my deductible, and
We
so
can.
let's just go ahead and have it done.
Oh, I mean, I can tell you, I don't care what the group is, right? You can pretty much plot most of them on a graph, predictably, right? And say, okay, it's going to fall off during the summer. It's going to start cranking back up. And then, as you get closer to the end of that plan year and that deductible, right? Then you're going to start seeing some more of those types of claims come on. And then, just be prepared because we got a little run out, when things turn over, into your next year, because you're going to have some people that waited, and some providers that waited to bill until, December or January, February. Some of them don't bill on time. And so you got that run out on a plan of like, okay, we know there's going to be some additional claims. I mean, that's, we do that all day long with clients. It's just, hey, understand this is what it looks like when you self-insure. It's not necessarily, I owe, $100,000 every month in insurance premiums. Your costs are going to kind of go up and down a little bit throughout the year based on usage. And that's what drives, that's exactly what drives usage is people's out-of-pocket costs, even when, and especially kind of the more they know about them, right? Like some of them, and you're exactly right. Most people don't make decisions based on quality because they don't have any idea. Like they don't know. 0%. Unless they have experienced it before, and they've had a bad experience, they don't know. They can't know, right? They're not doctors. They're not professionals. They're normal people, right? Who are not experts.
Yeah. And, it's especially true in musculoskeletal and it's medicine across the board, right? Everybody's on a bell curve. There are some clinicians who they're just not that great. We all wonder how they made it through school and passed their boards, but somehow they did it. Nobody likes them. They got terrible, scores on, patient satisfaction. There's always that group. And then there's, the average, okay, the top of the curve. This is where most people sit. And then there are the people who are obviously excellent. And this is what drives me nuts is the clinician who sucks and the one who has raised themselves to a position of excellence in the value they provide, they get paid the same. You know what I mean? And I think this is one of the things that I think will improve the healthcare system in terms of value and quality with price transparency is price transparency. It will create a race to the bottom in cost because people are going to price shop unless they're like going to die if they don't do something now. Like people going to the ER aren't price shopping. They're trying to get a problem solved very quickly. Everything else, it's going to drive price down. Competition always drives price down. But then I think it's going to allow people to separate their value. And the people who are going to get more business and pay the most, it's because people are going to choose, I'm going to pay this understanding that this is an average provider and that's fine with me, or I'm going to pay this because I want the absolute best. And it's going to totally weed out the providers that maybe should have been blown out of the marketplace.
It's
10 years ago.
It's going to help what it'll do, because we can see now quality scores, right?
Sure.
Recidivism, right? Not recidivism, but readmission rates in hospitals. We can see complication rates. We can see, rehab times, right? Things like that, right? Because I mean, it comes through in the billing and there's data that's on there. And like what I always like to do is kind of put it on for a client like a map, right? And say, okay, here are your providers, and show you that curve, right? That bell, and go, okay, here are the ones that are super excellent. They're worth the money, right? And then here are the ones that are not. And then they're the ones in the middle, right? The kind of greens, the yellows, and the reds. And so, to show them that, and it's like what price transparency will do is it will allow those bad providers it stops them from hiding, right? Hiding behind ignorance, because what we know about bad providers is that they actually have to usually charge more for their services because they get fewer referrals. They get who they like. Other providers know who they are, right? Yeah. They know that it's not a good experience. Patients get to know who they are eventually, and so in order to make the same amount of money, they have to charge. Their gross charges, right, get higher. So we know what that is, and it will allow them to stop hiding behind that. People will know, okay, you're too expensive. That's not good. And what it'll do eventually is probably just drive them out altogether. It'll either they get forced out, right, of business, or they got to go get better. So one or the other is going to have to happen. But yeah, no, price transparency will stop them from hiding, and it'll force them to either get better or get out of the market, which either way is to the benefit of patients and payers, right? So,
do you know currently, just kind of backtracking a little bit, like just talking about getting to the end of the year and seeing spikes in claims, no doubt due to the way people make decisions around their deductibles being met. Are there currently anything in place on like the primary care side or specialty side of incentives for a medical second opinion as like driving a wedge between people's deductibles being met, their thought process around that, and actually going and having a procedure done?
So there are different navigation strategies, right, around, okay, like the steps before you get to something big like a surgery, for sure. Yeah. And there's a lot of different kind of ways that like different groups try to put things in, and it really depends on like clinical best practice and what you're looking for, and what the disease is, right? So it's like, a cancer diagnosis, no, right? Like you probably, that's not really what we're looking for. There is outcome per cost, right? That's like, okay, where can you go get the best cancer care for the money? Where's the best place to go, right? That's not going to like blow you up, right? But is going to give you the best survival rate, right? Musculoskeletal MSK stuff or other things like that. Yeah, no, there absolutely is. And I think that's part of any good navigation strategy is to say, and we have clinical data. There's not a lot of guesswork in this, right? Of like, we know, right, that like if you can manage pain with PT, if you can manage pain with, other things that are not surgical, like, and heal a person that way, that's way better for the person and the payer, right? And the group, whoever it is. And if they're the same person, well then great, right? If the person is paying, that's better for them. Just, we know that statistically, we know that scientifically, than it is to go in and cut them up. Now, again, sometimes, you blow an ACL, you have to go have the surgery, right? It's not, then you do, right? But yes, for sure. Like, I mean, you put those navigation strategies in to go say, okay, let's go get a second opinion. Let's go take it's cheaper to do that than to jump right down the course of action, right? Because you can divert sometimes some of those things. I mean, there are hospital groups that, I've talked to that will tell you to your face that primary care is a loss leader. They treat it like a loss leader, and it's there to drive people to specialty care. And for clients, it's like, if what you're trying to do is manage healthcare costs, that's not the situation you want to find yourself in. You don't want people going to providers, going to their doctor saying my knee hurts, and the doctor's job is to send you to the orthopedic surgeon. Where he's getting sent. Though. That's what happens, and that's a lot of how it happens, right? Is like, okay, let me go send you to the orthopedic surgeon so he can tell you, all the sorts of cool Top Gun stuff he can do with a robot.
This is it's really interesting you mentioned that, because we noticed that inside of our own practice for the past 7 years. We I would say 98% of our clientele in the last 7 years have been people who had already done physical therapy, chiropractics, medications, injections, and quite a few of them had already had surgery, still had the pain unchanging. The interesting thing about the surgical candidates is they got rid of their pain for whatever their total rest period was, and then it came back. But what we noticed is that when people started at primary care for a pain condition, it was always attached to a prescription. There was probably just a glorified version of something you could get over the counter. And then it was a pretty quick referral to specialty. And what we noticed was that if we could just start people here instead of there, you could avoid the prescription, you could avoid the injection, you could avoid the MRI. That's one of our biggest peeves. Like, people are getting MRIs way too early in the diagnostic process for pain conditions. And that drives a different type of clinical decision making, especially if you've already stacked up Medications didn't work, injections didn't work, and therapy didn't totally take the pain away because not all therapy is created equal. And now you've got a lot of evidence that your pain condition is associated to the MRI, which, let's just say in the case of the low back, we got a tremendous amount of data around, 1 million Americans have herniations right now and have no pain. So, but the MRI has now been used to create diagnosis rather than confirm. And once people have a diagnosis, it's so difficult, or have an MRI, it's difficult to break them out of the mindset that creates, because now they think they're broken and they need fixing. And that's not been true for us in any case so far. And it's just, I think it's a slippery slope.
That same broken care model is why you have an opioid epidemic, right?
Sure.
People walk in, they're, right. It's okay. The provider, unfortunately, who because nobody gets a Percocet prescription themselves, right? Not legally, right?
Yeah.
They got to have a doctor write it. And like, how did that happen? How did doctors write so many, pain med prescriptions that half of America got addicted to painkillers? Well, because they're incentivized, because there's this broken care navigation model that's happening, right? That like, they're in there, I'm in pain. What do I do? Well, I can only see you for 20 minutes today because I've got to get enough people through to bill, right? Because I don't get reimbursed much for primary care because I'm part of this large medical network, right? And they want the big sexy stuff. So, okay, great. So I'm going to write you this prescription for this, this new G-Whiz drug that the pharmacy rep tells me is amazing. And I'm not going to look too hard at and think about too hard because, it's a fact, right? That like, the chemistry of opioids is like a med school 101 thing, right? Like everybody, I mean, sure, right? It's why opioids are addictive and also why they work, right? So doctors prescribing opioids, but not really thinking too hard about like, okay, is that drug rep really telling me the truth here? Like, is that really like, and you don't have the time to follow up with the patient and monitor them and do the kind of care quality that you would want because the navigation and delivery system is broken.
Sure.
And that's what happened. And you see it in, high cost claims all over the place that don't necessarily, need to happen. Right. But because this link between payer, patient, and provider is not a straight line, it's this very convoluted kind of back and forth system. There's a lot of room for things to go wrong like that in a big way, which they did, but also a lot of room for just a lot of chicanery and BS and stuff like that. And that's where, unfortunately, costs can kind of go nuts and get out of control.
Yeah. I think there's also like primary care physicians aren't trained that well on pain. I know several, they don't receive much in the way of musculoskeletal. I think as a generality, pain is largely misunderstood, or at least misapplied by almost all of medicine. It's viewed as the problem. Pain is the problem to be solved, rather than pain is the indication that you have one.
Right.
But it is not the problem itself. And so, the Band-Aids turn into the higher cost things because, you give some meloxicam and that Band-Aid's not big enough. And so then you go back to primary care and then you get referred to specialty and then it's an injection. And then that Band-Aid's not big enough to make the problem disappear. And then it just keeps escalate. And so,
I was a couple of years ago, I decided, try to get in shape and all that. And so I get back in the gym and I'm working with this trainer and about 3 or 4 months into it, I just started to have horrible knee pain. I mean, all the time, just really, really bad. Right. And I came in with a knee brace and he goes, "What the world's wrong with you?" And I'm like, "Well, my knee hurts." And he goes, I was like, I had a doctor's appointment scheduled and all this stuff. And he goes, "Well, what are you doing?" And he goes, "What'd you do? Did you like injure it? Did something pop?" I go, "No, it just hurts like hell all the time, And he goes, "All right." He goes, "Don't go to the doctor." He goes, "Pain's a sign that something's wrong. It's not like you have pain for a reason, right? Either you injured something or there's something else. If you didn't injure it," he goes, "there's a way to like work it out and work through it." And we kind of talked through it. He goes, "Most likely, because you're getting back and you're new to this and you're a little out of shape, those tendons and those, ligaments are also out of shape. And they're not liking being stretched and moved around. And so you need to strengthen the muscles around it. And so we put some stuff in, and sure enough, I mean, what, 2-3 weeks later, gone, just totally gone. Didn't have to take a pill, no surgery, no healthcare expense at all. Right. Like just took it and said, okay, what's the cause? Pain's a sign that something's going on. You have it for a reason. Why? Like, figure that out first before you go get drugs and surgeries and MRIs and tests and all this stuff.
Yeah. And we don't like dealing too much in probablys or assuming too much. Yeah, we've been able to, with a high degree of confidence, show people here's why. A physical capacity is definitely a piece of that. Like, if you have pain and you just continue to work out and it gets better, that just means that you had pain because whatever you were doing was more than your body could handle, and you did it long enough to where now you're just more resilient. That's one side. That's one side of physical capacity. The other side is functional mobility. Like, how do all the links in the kinetic chain affect all the other links in the kinetic chain? And if you
that was my problem.
Yeah, if you got a weak link somewhere, like the knee is never the knee's fault. The knee is something else's fault always. It's all pain. Pain never is where the problem is. Let's say your shoulder hurts because you have a rotator cuff tear. Okay, good for you. Why did you get the rotator cuff tear? That's the root cause of your pain, and that could be because of your ankle, depending on your lifestyle and the types of activities you're doing. We saw that a ton, especially when we were working with CrossFitters, watching them do an overhead squat, and it looked like total garbage and wrecked their shoulders because their ankle was so stiff. Not that there's anything wrong with overhead squatting. There's no bad movements. There's only bad movers. But when you watch people do very high level movement, you can see really quickly how this joint way over here is directly affecting this one way over here. And we saw that enough times to understand, like, oh, well, we could very easily screen for, like, oh, well, what are your missing links? Like, your joints should have a certain amount of motion available. And if you don't, that's a predictive mechanism for pain or injury in the future. Or it's the way forward to rehab yourself out of the problem. So we just systemized MSK screens around that.
Yeah, mine was ankle mobility.
Yeah, ankle.
Ankle mobility.
The knee is almost always the ankle.
It was because he sat down and he goes, okay, and he takes a look, at the different angles and all that, and he goes, your knee doesn't go far enough out over your foot. Like, he goes, so all the load is on that knee when it should be balanced, and he goes, the next one's going to be like a back or a hip or something, because it's just going to go right up to your, it's going to be a domino effect. So you got to work on ankle flexibility, ankle mobility. And sure enough, and that's what did it. And it was like, done, gone. Like, as soon as we fix that problem. So
this is one of my favorite things about MSK is I'm biased, but you'll get it. Most of, like, medicine, it's A=1. You have this symptom, it equals this drug. You have this condition, it equals this treatment pathway. Yeah. MSK, that gets applied to MSK a lot. You have this itis or osis, and it equals this TheraBand rotation. But that's the same as modulating pain with medicine. Most people are using PT just to modulate pain with movement. But MSK is really more like that stupid math where there's numbers and letters, and 1A plus 2B equals 3C. And we got to sort out several different things to really understand why is the stress stacking up in the body in that particular area. And it's not because something's wrong with that particular area. But the unique thing about that is that, like, people can't do their own blood work. They can't do their own mammograms. They can't do their own screening for what's under the hood. But you can teach people how much motion your joint should have and how to test it on their own. Or now you give them the opportunity to be able to self-assess. Am I working correctly? Yes or no. And then teach them, okay, well, if it's a no, how do you turn that into a yes? And as long as you know what good movement should look and feel like and how to turn no's into yeses, it's very easy to rehab. It's very easy to prevent. And it's very, very easy to solve your own problem should it come back. And that's a unique facet of MSK that's really difficult to do in other areas of medicine.
Yeah. For sure.
Hey, I want to shift gears with you for a second here. We were talking a little bit off camera, and you said something that I thought was really, really interesting about the mindset. Like, when you're working with a company, the mindset their people typically have, especially as that company has grown from maybe 1 or 200 people, and they've really grown as a company up to 800, 900, 1,000. But they kind of drag this small business mentality up with them into larger business. How do you see that affecting how they make decisions around healthcare and what's available to them, and kind of figuring out how do you play a new game now that you're a new company?
Yeah. So, the tough part about being that decision maker or being that person, that HR VP or that, the one who's having to make those decisions and think about it with their team is that, unlike sports, as you move up levels, there's higher levels of coaching. Somebody tell you what to do, right? And so the way you swung the bat when you were 16, 17, 18 years old and high school is not the way that you're going to approach hitting when you're in AA, AAA in the major leagues, right? It's just way different. And that's true for any sport, right? The way you prepare, all that stuff. Well, unfortunately, in business and life, there's often not a coach, right? And so what happens is, it is that mindset. It's that this is the way I learned to do it. This is the way I'm comfortable doing it. This is the way I know to do it. So this is how I'm going to do it now. And I'm just going to take that with me and apply that to this 12 or 15 or 2,000 life company that I did when we were 200 lives, and we're still going to look at that. And it's like, and this is where, I think for us, it's often about that education, that coaching of like, hey, look, like, okay, you like, it's different. You're at a different level. You're not a 25 life, small local company anymore. You have 200, 300, 400, 1,000, 5,000 lives, like there's more that you can do. Cause a lot of times they kind of look at what they're not, right? And they have this idea in their head of like a large company is Kraft Foods or Microsoft or Amazon, right? So we're not them. Well, no, but you're also not, a mom and pop either, and so it's like, how do you get that to evolve a little bit? I mean, I talked to one client that kept, group recently that they kept saying they were small. We're small. We're a little fish, he said. And they have 1,800.
How many employees?
1,800 employees, and their idea was like, well, we look at our claims and if our claims are higher than our insurance premium, then we can't do anything about that. And I told him, I was like, well, first off, you're not small. Like, and if you don't believe me, take a drive when we're done and count all the other businesses around you. And I guarantee you, none of them will have as many employees as you do. Right. Just go take an hour and drive around. Like, this isn't New York City. Like, right. None of them are going to have that many. So you're not you're not a small fish. But number two, like that idea, that calculation that you were doing when you were smaller of, just 1 and 2, like kind of you were saying, right? A equals 1 isn't true at your size. It's not, because you can lower that spend in different ways, right? And balance out higher cost claims, right? There are things you can do to reduce the cost of those claims. You don't know, you're just looking at claims, right? But for what? Where are you spending that money? Like when you're 25 employees, you don't really have a choice. Like it's insurance or bust, right? But when at that size, that's not true. You can look and say, okay, well, yeah, this person has, some disease, some condition that we're treating, but it's cheaper to treat it over here than it is over there. So I can do that now as a larger group. I can have that navigation. I can change that network or put in that different strategy that changes that. And now all of a sudden that A plus B equals C. Well, we got a lot more variables in there, that a lot more levers we can pull. And it's that change in mindset of like, hey, we're kind of in the big leagues now. And the way that we play the game is way different. And it's a little way more sophisticated in the employer's favor than it was when we were a lot smaller.
Yeah. What do you think that is? Like, let's say, you got a company, they got 200, 250 lives. At what employee count do your options really change?
Right about there. Maybe a little less, maybe at 200. Yeah.
Yeah. And then what's the next break point? Like, what are the break points where it's like, look, these are the options available to you here. When you get to here, your options change in a significant way.
So really it's about 150 to 200, depending on financial condition and that sort of stuff, right? Like
Yeah.
where they can take a hard look at like self-funding. You can do some self-funded stuff, smaller down market, but you have to have really strong partners and backstops, captives and co-ops and coalitions, and you got to have help,
Yeah.
right? You can do it, but you got to have help. Right about that 150 to 200 is where you can like reliably do it mostly yourself, with the right like consulting and partners, right? Or unless you're super sharp. And I've worked with a couple of CFOs that are like, they didn't, I was there just because they didn't want to do stuff and to run the numbers for them. They knew everything. I didn't tell them anything. Okay, I'm just here to help. So right about there, and then really your next cutoff is once you get into like the multiple thousands, 4, 5, 6. That's where you've got a big enough pool, a big, large group of people that you're into like some bigger stuff, right? Where you can start to bring in your like you've got, especially if they're concentrated, right? Geographically, you can really start to go like, all right, we're going to get a direct contract because I've got 2,000-3,000 employees that all live here in Phoenix or wherever, right? And I can go directly to the provider networks and negotiate my own prices because I've got the heft. And then the next one is like 10, 20, 30,000, right? Where you can truly, you don't do insurance, right? You are, you basically own an insurance company at that point. And that's kind of the way you look at it, right? Is like, you are a very small insurance company because you're paying everything, you're doing everything yourself. You're not, you got a few vendors, right? That you're putting stuff out on, but there's no stop loss anymore. There's no, it's all reserves. And at that point, insurance.
Really good. Do you think the number, with the new technologies coming out, virtual care, digital care, obviously being able to serve companies that have larger amounts of employees but different footprints, that's probably a great service. But what do you think now with services like that? Is the number you really need to have to make a dent for direct contracting getting smaller?
Yeah, it is. So direct contracting really used to depend on geography, right? So like, again, if I've got 1,000 employees, but they're in 40 locations across the country, I don't have a lot of market power in any one particular market, right?
Sure.
I just don't have enough people in, Des Moines and Cedar Rapids and Detroit and Miami and wherever else to go to providers and negotiate a cost. Right? Like it's that whole like union bargaining thing, right? Like if we don't have a big union, we don't bargain much. And that's kind of the way it was. But no, now you could do direct virtual primary care. You can do direct, like the things that can be done virtually do bring that down. Hospital visits are still, you have to have the geography in a place because it's a hospital, it's a location, it's a building, and I can't get surgery virtually, right? Right.
We haven't figured out how to dry needle over the internet yet.
Yeah. There's no virtual labor and delivery, right? Like that. Nobody's on Zoom coaching, right? Like that's got to be there. So, okay. But like the stuff that can be virtual, yes, it absolutely does kind of change that a little bit. And it opens up for smaller employers better options that they can do direct stuff like that. They can put in that virtual primary care. They can put in, actually, and an area where it really you're starting to see it is mental health services.
For sure.
Right. We have mental health parity law now, which is a regulation, a legal requirement. So, now we can have mental health services that can be virtual and can be direct because you'll see large claims that are mental health claims that are, a rehab or a counseling or something like that. And obviously an inpatient setting has to be in person, right? But all the rest of it before we get to the inpatient setting can be done virtually and in a better way than like a standard traditional EAP used to do, where it was just a hotline, right? That sometimes you waited on hold, sometimes it was really great, sometimes it wasn't. It was always kind of different to now.
We originally digitized what we do because I came out of my last like employed position for somebody else was with an on-site healthcare company. So it kind of opened my eyes into a facet of healthcare that I didn't even know about. And I was the on-site therapist. I was there during the day. I work normal hours like everybody else. And what I really noticed was that in this particular industry, and this would probably go the same for like logistics, industrial, warehousing, anything that falls into a category like that, second and third shift work really got the shaft for direct connect to me or even the primary care clinic that was on site. And I saw that as a real problem. So as I started growing and developing, I had that particular group in mind when I was, thinking about, okay, how are we going to systematize our results that we get, but do it in a way that can reach people who work odd hours, their second shift, their third shift. And my eyes were open second to, this could also serve the people who get the shaft because they got, 1,200 employees, but they're in like 92 different counties. It's like, oh boy, because they have the same problem as an organization that everybody else has, with less access to legitimate solution. And so, but I think that's interesting. I think there's going to be a lot more of that.
You're starting to see, I've seen vendors that will, do on-site clinics at much smaller. It used to be that, like, you're talking about those breakover points, right, of like employer size. It used to be that like on-site clinics were for big jumbo, because what are you doing? You're owning a doctor's office. That's what you're doing, right? You just own a practice, and it happens to sit in your building and only serve your employees, right? And so the only kind of employers that wanted to take on that sort of cost, or where it really made sense, were those bigger employers, because they have to do all the cost, the insurance, the malpractice, the payment of the doctor, all of it, right? All over it. Well, if you've got a vendor that can come in and do that anyway, and you just pay them a fee, right? But they own it and it's all their cost. You'll start to see that come down market too. So it's like, there's a lot of different stuff that is, I think these kind of virtual sort of revolutions, these different ideas are really starting to kind of come more and more into the market.
Yep. Yeah. I think you're right. So we're coming up on time here, and I want to be respectful of your time, but there's a couple more things that I think would be valuable to get to. I'm going to kind of smash two of them together. It's kind of coming back to some of our time pre-call, just talking through a couple of things. One, we were talking about a couple of things that you think like employers should really be listening for when it comes to their current broker or considering future broker.
Yeah.
And I kind of want to wedge this into some of the new like can of worms being opened with employees suing their employers for lack of fiduciary responsibility. And so I think those two kind of mesh together, because employers are going to have to start doing things differently. They're going to have to start paying attention to what they're doing. They're going to have to quit just accepting their 20% rate hike and saying that's just what our insurance did, because people are going to start catching wind. It's like, oh, well, you didn't even try to negotiate or whatever. So what are some things, like if you get a broker in front of you, we got some employers listening and they're considering their current broker or a future broker, what are some things they really need to watch out for, especially considering they need to be paying attention to how they're managing this in a responsible way, so they don't find themselves in a Wells Fargo or Johnson & Johnson situation.
Oh man, that stuff's coming. I mean, they're going to go after those big boys first, right, to set the law, and then they're going to start looking down market because it's all money, right? Once that gets set. So yeah. So, okay. Real quick, right? That fiduciary responsibility, you have to manage your plan funds, the health plan, with the same kind of fiduciary responsibility that you do for like a 401k, right? 401k guys, they get in trouble because they don't move the money fast enough. Well, healthcare is a lot more complex. There's a lot more ways. Wells Fargo, it's over their pharmacy costs. That's really the big sticker, is like, they did not do a great job holding that PBM accountable. And they're in trouble. They really are. So this is kind of the reporter in me. I'll give you some questions to kind of look for, some things that help smoke you out just to get that broker relationship right. It is, beware Just like with politicians and promises, right? Beware of brokers and their magic wands and their secret formulas and their special relationships that they all, right? Insurance is a regulated product. There's no special insurance. Nobody has secret insurance. Nobody has secret access to one thing or another. Okay. They just don't. They may know about something, but they don't have special access to it. They don't. But that's not how any of the vendors work. That's just if it were me and it was my business, anybody comes in claiming secret powers or special magic wand stuff, the absolute do not pass go, do not collect $200, get out. That's the big one. And then the other one is remember your fiduciary responsibility as an employer. It's yours, not your broker's. He does not have it's yours. You have it. So if we're not marketing and taking a look at the aspects of your plan, if you're on the sort of set it and forget it, easy button, hey, don't worry about it, kind of mentality, that should be a flashing red light for you that somebody's asleep at the switch, right? And because it's just like, again, things change. There is always, your broker should be looking at your data and your claims and the market and where things are. That's their job. That's what you're paying them for. And if they're not doing that and you're not given you that clear line of sight into your costs, what's driving it, and what your options are kind of every year and throughout the year. I mean, I've run into groups that, I said, how did you set your reserves for your funding plan? They said, oh, we just based it off what we did last year. Like, no, don't do that. That's financial malpractice. Don't do it. That sort of stuff. So those are the two big ones that I would tell you is beware of magic wands and easy buttons and special formulas and relationships, because they don't exist. It's all smoke and mirrors. And then, beware of the easy button and don't let people get lazy and demand your data. It's your data. Demand it. You should see it. Your finance people should know what it is. And you should have that clear line of sight every month, every quarter, every year into, as that data comes out, right, into what's going on in your plan, into what's going on with your group. Don't just get on we went through open enrollment. Thank God. Now we can forget about it for another 10 months. Don't do that. Don't let your broker do it either.
Yeah. No, I think that's really, really valuable insight. Human beings, there's just a tendency for complacency. And I think people say healthcare is broken. I say it is functioning exactly as it is designed. It is a flawless operation. It's just a racket. And so, when you add complexity to complacency, it's a recipe for disaster. So, I think employers, I'm a fan of capitalism, businesses drive the world forwards in innovation, and you can't pay your bills if you don't work for somebody in most cases. And so I just think there's a huge play to be made here, but it's going to start not only with better understanding how it works, but partnering with better people to help you make it work, and then just keeping an eagle eye on things. Yeah, I think you really hit the nail on the head. The easy button is not going to work here, and it never will. Unless healthcare, as we know it, disappears, there's not ever going to be an easy button. And so staying diligent, especially now, with some of the new things that have been rolling out, staying diligent, staying on top of things, I think is going to be really important. So we don't see, some really valuable businesses get in. Yeah,
you better
deep trouble.
If you're managing a health plan, you better have your data and you better know what it is and be able to say, I went and got the best deal possible and prove it. Not just look at your broker and go, did you, or because the attorney, that's not going to fly in court of, well, my broker said we got a good deal. No, you need to have it documented. It needs to be there. What happened when, right? Yeah. Know those contracts, because that's what they're going through now is they're going through those contracts line by line and going, this is out of whack, right? Like there are better rates. This is not great. And that's all. And now they're in court and it's too late.
Yep. All right, man. Well, I appreciate it. One last thing. If you could leave maybe our employers, maybe some aspiring brokers, some learning brokers. I know there's a lot of brokers entering the space. Good time for that. but they've got a lot to learn and they're seeking information. If there's one thing you could leave us with before we drop off here, what would it be?
Yeah, for sure. It's that you have more options than you think you do for employers. No matter your size, you have options, and don't think that you don't, because you do. And for brokers, always, like for me, always keep learning, look for the best way to do stuff. Don't let people tell you this is the way it's done. Because I think that's how we all get caught flat-footed. So yeah, I appreciate it, man. Thank you very much.
Yep, absolutely, man. Really great catching up with you today. We'll talk to you later.
Thank you. Bye.